So much. Yeah, I'm Lewis Hay. I'm one of the third year family medicine residents at Full Circle Health here in Boise. From Minnesota originally. Going back to Minnesota after graduation to do full spectrum family medicine minus OB. Yeah, we'll get started. So this is a QTC prolongation for primary care providers. And then yeah, disclosure. So this is for education, and I do not have any financial relationships to disclose. So the objectives of today's talk is firstly to understand what is QTC prolongation, what causes it, risk factors, what it causes, or like what its risks are, and then tools that can be used in primary care to either risk stratify or make good medical decisions in the setting of prolonged QTC. Sorry, I'm trying to minimize this. There we go. Um, so why is this important for primary care clinicians? We encounter a lot of medications that can prolong the QTC. It's also a very common source of warnings. I'm sure everyone here that practices medicine has gotten an epic alert for QTC monitoring, similar to this one. And there's been a lot of research on alarm fatigue, and this is one of those things that's commonly encountered and probably commonly ignored. Or maybe people worry about it a lot and do big workups that may or may not be indicated. So that's kind of what this is geared towards. How does it impact AHEX core topics? So interprofessional education. So there's a big interplay with QTC prolongation with between medicine or the prescribing clinician, pharmacy, and then nursing. And I'll touch on that. I have a slide kind of about that later on in the talk. Behavioral health integration, so psychiatric, so psychotropic, antipsychotics, as well as like a couple antidepressants are implicated in QT prolongation. It's one of the most common med classes that causes issues. So definitely a lot of interplay between primary care and then behavioral health consultants. Social determinants of health. I have a slide about this as well. So this does disproportionately affect underserved communities, and we'll talk about that a little bit later. So background, what is the QTC? Most people probably remember that you take the interval from when the Q wave starts to the end of the T wave. That's your QT interval. As I was kind of researching this topic, I appreciated some of the background on how to calculate it, but I was not aware that it is still recommended to manually calculate the QTC, unfortunately. The automated reads are they're an average of every single lead. And then it's kind of if the computer can't quite make out a T wave, or if some of the leads are kind of suboptimal, it can cause error in the calculation because they're taking an average and including values that they probably shouldn't have. So unfortunately, still recommended to calculate manually, but we'll talk about. I personally have never done this yet, but we'll talk about kind of how it's calculated and how you can kind of eyeball it as well, a little bit, or kind of a faster way to verify that the machine is giving you a good value. So there's two main methods to measure the QTC, and this is what the computer uses as well. The most recommended method is the tangent method. So you take the steepest slope, downward slope of the T wave, and then you take a line on the isoelectric line or the baseline, and where those two intersect is your end point for the QT interval. And obviously the beginning is that beginning of the Q wave. Um, and then that brings in more kind of cloudiness sometimes when there's things like U waves, especially. And then as we'll see later on, QTC prolongation, and then when it before it turns into torsades, it frequently has U waves. So this does impact things clinically quite a bit. And so this is kind of, I think, more in the weeds, and just to know that it exists and that you can look it up later, but just kind of how to deal with U waves if they're not connected. I don't know. Can you guys see my mouse? Can you see me moving my mouse? Yeah. Okay. So over here on the left, if the U wave is like clearly not connected, you ignore it and just use the T wave. Slightly connected, but not like, notched, you would still kind of use that downward slope of the T wave. But then over here on the right, we see a U wave that has kind of backed up into the T wave and it's notched, and then there you use the slope of the U. So it's sometimes referred to as a QU interval, but true QU intervals are almost never used. This is still considered a QT interval. But again, that's just kind of more to know that it exists, not something that I think that most like non-cardiologists need to have memorized. And then, so most people probably know that the QT changes based on the heart rate. It shortens the faster the heart rate is, and it elongates the shorter or the slower the heart rate goes. And so there's been countless formulas over the years to try to correct for this. Bazit's, I think, was one of the first. It was like 1922 or 1923. That one is very good. It's what most people use. It's, I think, what most of the algorithms on the automated reads use. The only problem is it really falls off outside of heart rate of 50 to 90. So below 50 and above 90, it really starts to deviate very quickly from what people consider to be like more of a true representation of the QTC. And so for that reason, the most recommended formula, especially if it's outside of that 50 to 90, is the Fredericia formula. But luckily, you don't really need to know much about that formula. There's an MD Calc that all you need to do is calculate the QT interval. That's the only kind of like independent variable that you need to plug in, besides the heart rate. You can tell from the formula here that you need to know the RR interval, but the RR interval is it's inversely proportional to the heart rate. So MD Calc can handle that for you. You just pick which formula you want, plug in the heart rate and the QT interval, and then it'll spit out a result. And then, so a lot of papers that deal with this recognize the burden of manually calculating a QT. And so what these authors recommended, they were examining asymptomatic athletes and trying to make recommendations on, broadly what people should be looking at, EKG wise in athletes. And so their kind of solution to that was to quickly calculate a QT anywhere in lead 2 or 5. Those are usually where you see the best T waves, and that's usually where it's recommended to calculate the QT. But any lead that has a really good T wave, you do one calculation. If it's within 10 milliseconds of the computer's QT, not the QTC, but the QT, you're pretty much reassured, because the only other thing the computer then needs to do is it needs to figure out the RR, and if it can't figure out their heart rate, what good is it? And then it needs to just plug in whatever formula it uses. So you can reasonably trust that if it can do the QT, it can obviously do the rest. There's some papers had recommendations that maybe only trained electrophysiologists or board certified cardiologists should be calculating QTs, a cardiology overread, but I think even those authors acknowledge that in primary care settings, and then also especially like outside of the United States in resource poor areas, that's pretty unrealistic. And there's been pretty robust data that you can teach nurses and second year medical students to calculate the QT very accurately in like an hour or two. So why do we care about prolonged QT? Because it is often associated, or can be associated, with a dangerous arrhythmia called torsade de pointes, commonly just called torsades, which is it's a kind of polymorphic VT that you can see kind of a brief example of here. It was named, so it translates to the twisting of the peaks in French, and it was named because the VT kind of alternates between this kind of high amplitude, low amplitude, high amplitude, low amplitude, and so it's kind of like twisting around the baseline or twisting around the isoelectric point. Um, Ventricular tachycardia is, quite often not compatible with life, so that's why it's so dangerous. That being said, torsades is usually self-limited, and I picked this rhythm strip as a good example of both how torsades looks right before it starts, and then the fact that most people will come out of it spontaneously. However, it can certainly either persist in pulseless VTach, or it can deteriorate into VFib. So we can see here, like usually what you'll see is some type of bradycardia, or a kind of like slow and then fast, or a few beats of slow, fast, slow kind of thing. You can see U waves here. So we've got kind of like this T wave and then a U wave coming in. Um, and just kind of elongating the repolarization. You can kind of eyeball that the QT is pretty long here. It's definitely, half or more of the RR interval. And then you can see, so here's the last normal beat, and then right here is a PAC. Usually what'll happen, depending on what causes the QTC prolongation, you'll get aberrancy with usually PVCs or bigeminy. And then you'll get a PVC that hits during repolarization, that hits on the T or shortly after, right on the U. In this case, it was a PAC that hits right there when repolarization is still happening, and then that just shoots into torsades there. Oh, and that's the R on T phenomenon, R wave over the T wave, that can precipitate um, BTAC torsades. So not all prolonged QT will put you at risk of torsades, but by definition, all torsades involves a prolonged QT. So torsades is defined as polymorphic ventricular tachycardia with a prolonged QT. It's just part of that kind of syndrome. Um, Multiple, hypotheses for like why this phenomenon is seen. Like, so for example, take the drug amiodarone. So amiodarone reliably prolongs the QT, but does not cause torsades. So that one probably, it has its own like anti-arrhythmic properties. But we also see this with other medications. It's exceedingly rare that a single medication, a single QT prolonging medication, in the absence of intrinsic risk factors to the patient, um, causes torsades. But you can see profound QT prolongation without torsades, and this kind of repolarization reserve hypothesis explains that. I really tried my best not to put a cardiac myocyte depolarization and repolarization thing in anywhere in this presentation because it's, anyway. But this I thought was kind of a useful graph. There are a lot of ion channels that are involved in repolarization specifically. So everything after this kind of dotted line, all I could remember was, maybe a couple potassium channels and a sodium and maybe a calcium, but there's quite a bit, as you can see here. And so the hypothesis is you knock one out and you still have a robust mechanism for repolarization left over. And so it's kind of like the multiple hit theory hypothesis in cancer, right? That you need to knock out a couple different things, a couple different protective mechanisms to cause a clinically significant problem. Um, and then, just kind of conversely, the other way, they've also showed that you can take an animal that otherwise would go into torsades, give them a medication, keep their QT interval exactly the same, so prolonged, but still prevent torsades. So this kind of shows that torsades and prolonged QT are related, but not necessarily. They don't always correlate one to one. It's not 100% causative. So these are the main kind of risk factors to kind of consider in patients if you're worried about torsades and you're adding a medication that has a risk of torsades. Female sex, I think it's something like 70%, or somewhere around there, of patients with torsades are female. Age greater than 65, again, these are probably two of the biggest risk factors, actually, interestingly. And then cardiac, you've got bradycardia, obviously history of torsades, what's a risk factor for anything in medicine, a history of that thing. And then heart failure and acute MI can also put you at greater risk of torsades. Electrolyte abnormalities, so specifically hypo, low potassium, low magnesium, low calcium. Less so with the low calcium, but it is certainly a consideration, but not nearly as implicated as hypokalemia and hypomagnesemia. And then being on two or more QT prolonging agents or agents that are associated with torsades. And then it in many medications, it really does appear to be dose dependent and then just based on the route of administration as well. So oral carries a lower risk than IV push. And the thought there is that you're blocking most drugs that prolong the QT act on the rapid potassium channel. And so you just, uh, down-regulating that channel too fast for the other kind of compensatory mechanisms to help out. And then similarly, anything that can interfere with the clearance of a drug that prolongs the QT, so renal impairment, hepatic impairment, or drug-drug interactions that causes slower metabolism of that agent. And then genetics. So there's many different gene mutations that cause what's called a congenital long QT syndrome, which is the LQTS thing here. Um, of those, really, all we can reasonably control is the patient's electrolytes and what kind of drugs we're giving them. You certainly optimize, some of the cardiac things. Oh, here, I think this was not on the other slide either. So this one is important as well. So risk factors for torsades, if they're if their QTC is greater than 500 or if it increases by greater than 60 after starting that drug. Um, that's another really kind of important one. But anyway, the modifiable ones, electrolytes, which medication you're choosing, which dose you're choosing, which route you're choosing, and then other things that kind of impact that, like drug-drug interactions or dose adjustments for clearance. Congenital long QT, that is a lecture in and of itself, but I'll just kind of briefly touch on that because it is fairly common, and especially in patients that are diagnosed with quote unquote acquired long QT. There's been some good research showing that about 30% of those patients that are called acquired long QT carry at least one of those mutations for a congenital long QT. So again, really, there almost always has to be something else going on besides a single drug prolonging the QT to cause a problem. It's a very heterogeneous disease, so it's depends on how many copies of each mutation you have and how many of the mutations you have. So it can be, it can cause absolutely no problems, or it can cause, very severe problems even in the absence of high risk medications. It's always good to ask about family history of sudden cardiac death, probably in anyone, but especially, if you're thinking about, if you're worried at all about their QT, that's a good thing to ask about. And then, yeah, there is no recommendation for routine genetic screening for asymptomatic patients. If you're thinking about starting a drug, you don't just screen everyone. It's probably fairly obvious. Um, so what is a prolonged baseline QTC? I remember starting residency, I probably remembered, like around 450 or something, and then, somewhere along the line, someone told me, "Oh, don't worry unless it's over 500." It's always kind of been like a kind of a nebulous thing. Looking at some of the data, it's I kind of like the 450 and 470 values, and the reason I like those is they're based on percentile. So those are the 99th percentile for adult men and adult women. As we age, the QTC prolongs in everyone. So men and women, the QTC actually starts to converge. They start to get a little bit closer. But in general, these are good values that you can be reasonably reassured that if they're under this value, they are pretty low risk. There's been case reports of torsades happening at QTCs below 470 for women, 450 for men, but very rare. And so yeah, I thought that was kind of a better way to think of it. I had never thought of it as like kind of thinking about it as percentiles, but anyway. There's a normogram as well, which I thought was really cool. Is another one of those things that I think is useful to know it exists, and that you can look it up. The nice thing about the QT normogram is that it is not QTC. So this is the absolute QT that you can calculate on the EKG in front of you anywhere, and it should correspond to a QT anywhere else. And then the reason that you need a normogram is because obviously something needs to correct for heart rate, and this normogram does that for you. And this, I wanted to include a figure. They had a really cool figure of plotted cases of torsades, um, and they all fall above this line. It was a very cool figure. So I think the use of this figure is if you plot your patient on this normogram and they're below this line, you can virtually forget about torsades, at least for that moment, right? Because the QTC is dynamic. But again, yeah, I thought this was kind of a cool tool, but it is very conservative because if you see here, it never goes above 470. So probably a little bit less useful in that regard. So medications, especially those that we commonly see in primary care, antipsychotic medications are the most implicated in torsades. This study, this is not saying that 75% of torsades cases everywhere are related to antipsychotic, but I thought that this was a really interesting statistic that we think about supertherapeutic dosing or poisoning or overdoses, whatever. But this study found that in psychotropic medication associated torsades, about 75% of them are at therapeutic doses, so they're not inappropriately dosed at all, which is a little bit scary. Antidepressants, but only so of the SSRIs, I should say, only citalopram and escitalopram. It does not appear to be a class effect of SSRIs. It is truly those, and that's why you'll see, I think on like UpToDate or Lexicomp, where you look for dosing, there's a escitalopram maxes out at 20 or 40, but then they say rarely, clinicians go as high as 60 or whatever. That's where that recommendation came from. We used to use citalopram and escitalopram at higher doses, and the problem that they ran into was QTC prolongation. So that being said, that is good to know that, if you have a patient with a normal low QTC, that you can push the doses of citalopram and escitalopram a little bit higher. Antibiotics, especially fluoroquinolones, antiemetics. And then methadone is kind of a beast all on its own. We'll talk about that just a little bit, but that one is very much implicated in both prolonged QT and torsades. Torsades, by and large, occurs at QTCs above 500, and then, like I said earlier, it's exceedingly rare for a single medication to cause torsades. A single medication can cause QT prolongation, but for a single medication in the absence of risk factors, it's very, very rare. This study it's a fairly large study, found that 92% of drug-associated torsades had at least one other strong risk factor, and those were those risk factors that we kind of talked about a couple slides ago. So of the medications that are associated with torsades, anytime a patient is on multiple antipsychotics, that's one of the highest risk situations. And then polypharmacy with any of these medications is kind of what these authors discussed. So azithromycin, methadone, sotalol, which isn't used much anymore, and then these ones which I at least have never used. Um, there's over 200 medications that are implicated to prolong the QT, and have some sort of either known, conditional, or unknown risk of torsades, and it's very nebulous. So I kind of wanted to just boil down what is relevant for primary care clinicians and how can you quickly assess risk and figure out, is this something I need to be worried about in this patient or not? And the two best tools I found for that are databases. We'll talk about those. Those are mostly Credible Meds, and then they just came up with a new one. I haven't had time to dig into that, but I think they have an app and something where you can upload all the patient's medications, and it does some kind of analysis. But anyway, Credible Meds is usually where like pharmacists will kind of recommend that you look. It's free to sign up for any clinician in the United States. I think you need an MPI number, or maybe just an email address associated with the place of work, but free to sign up. And then there's an app for Credible Meds, so you can just plug in the name of a medication and I'll show you a little bit later kind of how it summarizes the data. And then the other way is through expert consensus or recommendations, basically, because this is an area of active research. It's very nuanced. It's controversial. There's a lot of differing opinions about exactly what causes torsades and the relationship between the prolonged QT and torsades and the risk of different medications. And it's all based off of observational data, right? Like medication goes on the market, and then these databases like Credible Meds will get reports of torsades or prolonged QT, and that's how this data is compiled. So for databases, Credible Meds, this is kind of what it looks like after you've logged in and you go to their search function. So you search the medicine up here, and then it will classify them into one of these three categories, or no risk or no data. But these categories, so a known risk means that they, one, prolong the QT, and have clearly been established that they are a risk factor for torsades based off of enough observational data. Um, and then possible risk, they are known to prolong the QT, but there is not any evidence of risk of torsades right now. So meaning there have not been significant case reports that definitively, or the overwhelming evidence is that that drug was implicated in the torsades. And then conditional is they can be associated with torsades, but only under certain circumstances, i.e., like large doses, electrolyte abnormalities, drug-drug interactions, kind of some of those other things that we were talking about. Um, so this is what it looks like when you search for a drug. So here I searched for metoclopramide. It gives you the brand names, the class of medication, what it's used for, and then a couple links. So here we can see that metoclopramide has a conditional risk of torsades. And if you click on that, it brings this up. So you got the drug name again here, and then the conditions that it may be associated with torsades in. So bradycardia, electrolyte abnormalities, polypharmacy, and then congenital long QT. And then down here, it on the drug label itself does not mention a risk of QT prolongation nor torsades. Um, and then if you click this link, I really like this. I think this is really cool. So for any medication, it'll automatically pull up a PubMed search in a new browser, searching for that drug and QT or torsade. And so then you can look at all the articles. So for metoclopramide, there's 43 articles. That's not terrible, right? So you can go through the kind of articles that way. So as far as expert guidelines, so this is a difficult thing to do, it seems, from reading the guidelines. This was by far the best guideline that I could find. There are a couple other ones, but they're usually pretty specific. Like they're either inpatient specific, so how to manage an inpatient, or they are very much psychiatry specific. This one was published by the Association of Medicine and Psychiatry, and they convened a number of experts in the field to talk about medications of all classes, so not just psychiatric medications, but all of the kind of most commonly associated QTC prolonging medications. And this is what their expert panel came up with. So they recommended calculating this risk score first. There are a couple other risk scores that you can use. There's a Tisdale score, I think, but this one is the only one that I could find that has this clear recommendation based on the score. And so you basically plug your patient into this. So 1 point for female, 1 point for age over 65, et cetera, et cetera. If you get a score less than 2, so 0 or 1, and you're thinking about prescribing a new medication that you know can prolong the QTC, you do not need to get an EKG. So let's say you have a 40-year-old female without any of these other things, and you want to give her azithromycin or whatever it is. Some people get nervous and get an EKG. This expert panel said no. If there's only 1 point based on these risk factors, no baseline EKG is needed. If they have a score of 2 or higher, they would recommend getting an EKG prior to starting the medication. And then if you can pick a medication that is lower risk. But otherwise, as long as their score is less than 5, based on their baseline EKG, you calculate their QTC. If it's less than those 99th percentile values, so for men, less than 450, less than 470, but you're still worried based on the risk factors and based on the fact that their QTC may go up with this new medication, according to this algorithm, you start the medication, repeat an EKG in 2 to 4 weeks, and like after they've started that medication, and then anytime you're increasing the dose or anything, and then thereafter they recommend annually. Some papers recommend like 6 months to 12 months, but yeah, somewhere around 6 to 12 months, monitoring patients that are chronically on those medications. Obviously, if it's just short course of an antibiotic, then there's no need to continually monitor them. If their QTC is above those values, but still less than 500, Then they recommend checking electrolytes, repeat EKG in 2 to 4 weeks, and then making sure that you're choosing, like, do they really need this medication right now? Is there any other medication I can give them? If you absolutely have to use that medication, then just bring them back in a couple weeks. Make sure you're following up on the labs. And then obviously, looking for polypharmacy, looking for any renal impairment, things that could also be modified. And then if the baseline QTC is above 500, check lights, and then yes, more strongly consider an alternative drug, or a drug with a lower risk, and then consider cardiology referral. And then we'll use this with a case study as well. Um, and then this guideline, a little bit newer, a couple years newer, from the American Heart Association. This is not as much of a comprehensive guideline. This is about all drug-induced arrhythmias, and basically it's just split up into 3 or 4 medium-sized paragraphs of atrial arrhythmias, ventricular arrhythmias, et cetera. And they just have kind of a short paragraph on QT, and this is their recommendation in the outpatient setting. They briefly kind of touch on inpatient, but again, this lecture is focused more on outpatient management. So they say if you're prescribing a drug that carries with it risk of torsades, not necessarily QT, but torsades itself. You just want to correct any modifiable risk factors, just like the other algorithm says. So check their electrolytes, make sure they don't have drug-drug interactions or renal clearance, hepatic clearance issues. If they are on drugs that are known to cause torsades, monitor them. Make sure that their QTC is less than 500. If it's above 500, try to figure out why. Try to take them off of that medication. Just try to keep them below 500 was their recommendation. And then this was where, long-term use of drugs known to cause torsades, they're a little bit more conservative. They recommend monitoring the QTC every 3 to 6 months, versus the kind of annual in the guideline before. And then they have a special recommendation for methadone. Methadone is a very high risk medication. Not a lot of us are primarily managing this, but very good to know for patients of ours that are on methadone, and we are also worried about their QTC. So they recommend a baseline 30 days after initiation, or a significant dose increase. They didn't define a dose increase. Another paper I saw, I think, was like 20 or 30% dose increase. They would get another EKG. And then if they're on above 120 milligrams a day, make sure you get an EKG annually. So how do we use all this and apply it to our patients? So we need to be aware that a lot of the medications we commonly prescribe are associated with QT prolongation, but recognizing that risk of QT prolongation is not the same as the risk of torsades. So that, um, QTC going up by 20, 30 points isn't necessarily concerning. It's not necessarily going to cause torsades. And then it's a very complex relationship between kind of the patient's own environment. There are genetic factors, age, sex, renal impairment, all those kind of things that we can't do a lot about, or in some cases nothing about, obviously. And then with the drugs that we're giving them, it's not kind of a one-to-one. Clinicians can use the databases like Credible Meds. I've shown you a couple expert recommendations. Hopefully more will come out at some point. And then just be aware that if you have a patient that you're worried, and this is kind of how I think I'm going to use this information of manually calculating the QT. I don't think I'm going to start manually calculating QTs on all of my EKGs, but it's good to know that it's not terribly overwhelming to do. And that it is good to verify. So, I think if you had a patient that was borderline, if you calculated the QTC and you got a value that is much more reassuring, that you either, if you have the kind of confidence in how you calculated the QTC, then maybe you forge ahead with your plan, or maybe that prompts you to ask for a cardiology overread and just have a cardiologist manually calculate the QTC to confirm your value. Watch for changes on the automated reads. Every year, people are coming up with new things. This paper that I found was an iPhone app that could uh, automatically calculate the QT interval, and they found it did it pretty robustly. So for some reason, the very expensive EKG machines at the hospital, people seem to have less confidence in. But yeah, hopefully one day that will change. So I thought we would go through a case study briefly here. So this is a patient that I picked that I thought would kind of represent a common scenario that a primary care physician would find themselves in. So a 68-year-old female presents for depression follow-up. She has a past medical history of hypertension, type 2 diabetes, CKD, and then fairly refractory depression. Let's say that she's tried multiple agents, multiple SSRIs, um, and titrated her up to sertraline, 100 milligrams, and she is just feeling awful. Her depression is still very much poorly treated. She's also on lisinopril, metformin, hydrochlorothiazide. And let's say you're the clinician and you're thinking about switching to escitalopram. Let's say that's one of the ones she hasn't tried, or possibly adding an atypical antipsychotic. Or let's say you have recommendations from their psych provider, but they wanted your go ahead to start that medication. Um, but you remember that escitalopram and then most of the antipsychotics are associated with QT and Torsades risk. So what do you do? Well, you could plug her into the risk assessment tool that the Society for Medicine and Psychiatry recommends. So looking at her risk factors, I calculate a score of 4. She's age greater than 65, female. She's on a diuretic, and she has renal impairment. So can't go down this route. We need an EKG. So let's say we get a baseline EKG, and unfortunately, it's 472, slightly too high. And then following those guidelines, you do what the guidelines say, and you get her labs, and her potassium and her magnesium are a little bit low. So go down the algorithm, replace to a goal of 4.0. Some resources say 4.5. That's more kind of inpatient and like more like high risk cardiac patients. Generally, the recommendations that I found for kind of outpatient is targeted potassium of 4 or higher, magnesium of 2 or higher. So let's say we do that. We give her a prescription for oral potassium and magnesium. She follows up 2 weeks later. And we're thinking maybe we'll add aripiprazole, or maybe we need to figure out an alternative if we can't fix the QTC. So she comes back 2 weeks later. We've now optimized her electrolytes. We get another EKG, and her QTC is 458. So this puts her now in that first box category, where you can start that medication. So let's say we start the aripiprazole and then follow up in a month, and then maybe in 3 months, to be kind of more conservative, or 6 months, I think would be reasonable. So that's just, it's obviously very contrived and worked out perfectly. But just kind of it's less, I think it's less nebulous than I thought. What do I'm worried about the QTC, I'm going to get an EKG. Okay, now the QTC is this, and I don't really know what to do with it. So I found this kind of algorithm very helpful and reassuring. Um, and then transitioning this topic. So how does this topic fill a need or gap in serving underserved communities? So a couple things that I found in the research. So methadone is a very high risk medication, as I've talked about, and methadone is disproportionately used in underserved areas. So people that live in underserved areas and are of underserved populations disproportionately get methadone instead of Suboxone, and they are therefore at greater risk of QT prolongation and torsades. Sudden cardiac death, from all causes of sudden cardiac death, is disproportionately seen in underserved communities. Underserved communities obviously have lower access to EKG and cardiology referrals. And then tuberculosis treatment, just because of the antibiotic regimen, is very high risk for QT prolongation and torsades, and tuberculosis obviously affects underserved populations at a much higher rate. And then I mentioned interprofessional education is kind of one of the goals of AHEC and how this topic fits into that. Almost all papers that talk about this risk as a public in a public health context really hammer home the relationship between the prescribing clinician, the pharmacist, and nursing staff. So nursing staff kind of more applicable to the inpatient setting, but outpatient definitely pharmacy. Um, Pharmacists are often the ones that catch this, that catch a high risk medication in a high risk patient. And so, education for pharmacy students, pharmacy residents is very important on this topic. And then they've done a randomized controlled trial to show that pharmacy education, if you take one group of patients when they pick up their prescription, gets education from a pharmacist specifically about QT prolongation, and they go through the risk factors with the patient. The other group didn't, and lo and behold, the group that got the education had fewer adverse events. And then this is a really common issue for pharmacists. So one study in the kind of pharmacy literature, 23% of outpatient pharmacy clients that were coming in filled drugs known to cause or known to cause prolonged QTC. And around 9% and this is all patients, all comers, all visitors to that pharmacy or those pharmacies that they were studying, around 9% were on two or more prolonged drugs. So a very, very common scenario for both physicians and pharmacists. Um, that is it. I'll open up to questions. A couple other things I wanted to touch on briefly. I'm glad I have time. I didn't want to write them down in my presentation because I it's so the reason is it's really hard to prove a negative, right? And so trying to find that a drug is not at risk for torsades, that's a harder thing to prove than it is, right? So obviously do your own research, but the consensus seems to be especially for the antiemetics, that they are a lot lower risk than we think. Zofran, a common one that people think of as prolonging the QTC, the research for that was done in incredibly high doses, chemotherapy doses. So they're using it to prophylax against really high risk chemotherapy, and they're pushing 32 milligrams IV routinely, much higher doses than we are using. And as far as I could tell from an MRAP podcast, an article I found, and then searching through the literature myself, there has never been a report of torsades from oral Zofran, hands down, ever. That was reassuring to me. I know as a brand new intern, I was always afraid to prescribe Zofran inpatient for people that had slightly prolonged QTs, and every time I would call the pharmacist, they would say, just give it anyway. And I think that's why, is because the research is there because we do use Zofran at really high doses, but almost exclusively in an oncology setting, the doses that we're using. And then also, I believe there has never been a case of torsades from a single IV push of, I can't remember if it was 4 or 8 milligrams of Zofran. So bottom line, Zofran, incredibly safe. Only a few case reports of torsades, and it's there at extremely high doses. And then Reglan, the one that we searched, as far as I could tell, has never itself been implicated in torsades. So those are compazine, phenigrin. I think those are a little bit, those do have a little bit more data to show that they're a little bit riskier, but it seems like the safest medication, at least from the data, you can always reach for Reglan, and then Zofran at the doses that we commonly use are pretty much a non-issue. But again, please do your own research. Um, yeah, that's it. These are my references. I think there's another page. Um, couple shout outs in the references. Life in the Fast Lane has a lot of really good EKG libraries. That's where I got that rhythm strip from. They have a really good article on torsades and kind of how to identify signs of kind of like impending torsades and kind of the natural history and evolution of torsades in a number of different settings. It's really cool. They go through a case of hypothermia, they go through a case of hypokalemia, and a few other cases, and they have the entire rhythm strip from before the torsades and then as the torsades develops. It's a really cool resource. And then I think that's about it. This Tisdale paper is a good one. That was the consensus statement. But this author he's a fairly prolific publisher in the realm of prolonged QTs, and he has his own risk score. So yeah. I'll open it up to any questions. I'm
Dr.
curious.
Hay, oh, sorry. I was going to say there's a couple questions or
Oh yeah,
comments in
I
the
can't see
chat.
the chat. Yeah, let's see, how
Okay.
can uh, let's see. Oh yeah, okay. Um, oh, excellent question, Chris. AFib. I almost had Chris asked how do you calculate QTC and AFib? Very good question. I I almost included a slide on how to do that, and I thought, no, that's way too much information. Yes, exactly. You take the average RR. So in non-AFib or a non for a regular rhythm, you can just use the preceding RR. But in AFib, there's a couple ways to do it. You can take an average. Some people recommend taking an average of 10 RR intervals and 10 QTs. And then using that in the formula. Some people recommend like 2 to 3. But yes, it's in some way it has to be an average for any irregular rhythm, not just AFib, but sinus arrhythmia, same thing. You would need to average. Um, then Dr. Bastian's question. Yes, I know. Most of kind of when I was researching this topic, most of this was by and large reassuring. I mean, like very, very reassuring from especially like azithromycin kind of thing. Although, the fluoroquinolones are kind of they are a little bit higher risk. So yeah, I would say after doing all this reading, I would have more respect for azithromycin probably than I did before. Um, but again, yeah, there's not a clear consensus, and I think if anything, a lot of the literature says that we worry about this too much. We get too many baseline EKGs. But that being said, yes, female over 65, I guess technically. It sounds like she might have a couple other risk factors too. You could yeah, you could definitely consider getting a baseline EKG, but I wouldn't beat yourself up for not getting one either. And then another question, is there any lead that you would not use to manually assess the QTC? We recently had a case last week where V2 was the clearest but could not discern on 2 or 5. Yeah, so the recommendations for lead 2 and V5 is just that those are most commonly where the clearest and best T waves are seen. However, the recommendation is always to use whatever lead the T waves can be most clearly seen, and that downward slope intersecting with the isoelectric point. So it doesn't really matter which lead you use. It's just most people recommend 2 and V5 because those are kind of the standards for good T wave morphologies. Couple other nuanced things. So the automated EKG machines take a global average of all of the leads. You can do a similar thing that some authors recommend, especially if it looks funny, kind of just like when you eyeball it. They then recommend if you do calculate the QTC manually in multiple leads, take whichever lead is longer. So you err on the side of being more conservative. That you take the longest QTC. So if you're in doubt, or if it's you're having to use a lead and you're like, oh, is this right? You can always check another lead and try to just calculate a single QTC and see if they kind of agree. But yeah, there's no reason that lead 2 or E5 give a more accurate QTC by themselves. They just usually lend themselves to an easier calculation. Has anyone ever calculated a manual QTC? I'm curious. And was it easy? That's yeah. Otherwise, if no one else has any questions, we can end a little bit early.